hospital budgets for fiscal year 26. This morning, we have an overview by our hospital health systems finance team. And then this afternoon, we have Mount Ascutney and Southern Vermont Medical Center's budget presentations and hearing. So I'll turn it to our Director of Health Systems Finance, Mr. Sutter, for the agenda that he's prepared and an overview.
Thank you, Chair Foster. Give me 1 minute to get the slide deck. Okay, is that showing all right for everyone?
It is.
Great, thank you so much. Like Chair Foster said, we're going to discuss the FY26 budget submissions today, some preliminary staff analysis. Very quickly, I'll run through our agenda. For background, my colleague Emma Runya is going to run through some slides discussing hospital spending in Vermont, discuss the insurance market here, some experiences we've seen with hospital expenses since the pandemic, briefly mention what's going on with Blue Cross Blue Shield, and then what we're doing currently to kind of address the issues we're seeing. Then Mark Henksler from our legal team is going to run through statute, rule, and guidance for us and present some draft standard budget conditions. And then I will conclude by going through a summary of the FY26 budget submissions. So without further ado, I will pass it to Emma.
Great, thanks, Matt. Good morning, everyone. I'm just going to start us off with a bit of context and really how we got to this point today. So when we're looking at the state personal healthcare spend, what we see from this chart overall is that hospitals are the largest sector of personal healthcare spending in Vermont. We see that it's over 45% now. And what we can also see from this chart is that it's grown from 2018. So that's that dark blue bar. It looks like it's a little over 40%, and that's grown to over 45% to 2022. So we're seeing that concentration of spending to hospitals is growing, and noticeably the only other sector that we see growing here is prescription drugs and non-durables. And so we kind of start with this just to give us an emphasis on why it's so important that we look at hospitals so closely, as they're such a large sector of our spending for healthcare in Vermont. Looking at the makeup of these hospitals, what we see is that for inpatient discharges, system-wide in 2024, over 80% of inpatient discharges that were submitted in VCures were by non-commercial insurers. So we see it's about 52% for Medicare, Medicare Advantage, and about 28% for Vermont Medicaid, which leaves less than 20% for commercial insurance. And that's overall across all hospitals. What we're seeing here with this is that we're heavy on that non-commercial sector in Vermont. These are, of course, from VCures, so there are some populations missing, but overall, broad strokes, what we're seeing is that there's this heavy emphasis or inclusion of Medicare, Medicare Advantage, and Medicaid, which makes sense given our demographics in Vermont. And we also see that this varies pretty significantly by hospital. So notably, we could look at like a Grace Cottage or a Mount Ascutney, which has got 95 and 87 almost percent, respectively, Medicare spending. Again, this is just inpatient, but it's a good indicator of kind of how much this varies between hospitals, as well as overall looking at the reliance on public payers. So if we're looking at these different payers, we can then look at their inpatient payment to cost ratio. Generally speaking, just thinking about it, looking at as if it's above 100%, then that payment is covering the cost, and so they're making money on these services. Whereas if it's less than 100%, the payment does not cover the cost, and so they're losing money on those services. And so what we see is that for commercial insurance, that's at 140% overall across hospitals, whereas this drops down for Medicare, Medicare Advantage down to about 82%, and Vermont Medicaid down to 56.5%. And again, we see a lot of variation here across hospitals. We see actually, in fact, 4 of our hospitals for inpatient services are not hitting that 100% or that break-even point for commercial insurance. But notably for CVMC, they are hitting that 100% for Medicare and Medicare Advantage. And then also just to point out once again that critical access hospitals are cost-based reimbursement for Medicare. And so that really helps. For example, in that last slide, we saw Mount Ascutney and Grace being so high for that Medicare population that it's really helpful for some of our smaller hospitals and for our critical access hospitals to get that cost plus reimbursement for Medicare. When we look at the story for outpatient, it's really only more dramatic. We see that commercial insurance rate goes up to 235% for the payment to cost ratio. But for Medicare and Medicare Advantage, this drops down to 73%. And for Vermont Medicaid, it drops down to less than 53%. So we're seeing that, and this is something that we've seen in other sources as well, that Vermont's outpatient prices are higher relative to other states and to other groups than our inpatient prices are. So this makes sense with what we've been seeing. And again, we see a lot of variation within these as well. So it's less than 150% at a hospital like Gifford, but that goes up to 293% at Rutland. And we see some other facts as well. Again, seeing critical access getting paid the same and getting paid that cost plus reimbursement, as well as a hospital like Brattleboro getting just 22% payment to cost ratio for Medicare. So what we're looking at here is that Vermont seems to have this high percentage or high proportion of public payers, most of which can't cover the cost of services, of course, kind of putting aside Medicare for critical access hospitals. And so when we're looking at the cost, right, because we have payment to cost ratio, we can't really impact the payment for these public payers, but we can impact, or, hospitals can have an influence on their costs and their expenses. But when we look at this growth in operating expenses from 2019 to 2026, what we're seeing is a 53% growth for compound annual growth rate. That's over 6% from 2.8 billion in 2019 to budgeted 4.28 billion in 2026. So you're seeing expenses have grown enormously. And again, if we're looking at this problem of having lots of public payers and not covering costs, this is only going to continue to widen that gap of not being able to cover costs with payments that are fairly inflexible and we don't really have power to change. Historically, we've looked to the commercial market to be able to cover these costs for us. But that's really not an option anymore. Financial struggles, this is a couple of headlines from Blue Cross Blue Shield Vermont, have pushed Vermont's largest health insurer to the brink. We've heard lots about their insolvency and concerns around insolvency, as well as them announcing a $62.1 million deficit for 2024. So what we're seeing from this is another year of double-digit rate increases due to these solvency concerns, higher prices and higher premiums for Vermonters. And this is really not something that we've been talking about this for a while now. It's not a path we can go down. It's not the way that forward. We need to find other ways to be able to change the system. And in this slide, we also just once again see that Blue Cross Blue Shield of Vermont's rate filings again this year were in the double digits. And on the right, there is a quote or a public comment each year during the rate review process. Hardworking, decent Vermonters are forced to come here before the GMCB. And so here we are, another year, another double-digit increase. Our Vermonters are feeling it. Small businesses are feeling it. We cannot keep putting any more pressure or strain on the commercial market. That's not the path forward. And so it's really important for us to kind of start looking at other ways to do this. And so now we're going to talk a little bit about how we're kind of dealing with this as a state. We're starting to. So first, and this is probably most impactful to the 26 budget submissions that we're talking about today, is capping outpatient pharmacy prices. So H.266 or Act 55 now states that the reimbursement of a prescription drug administered in an outpatient office setting must not exceed 120% of average sales price. This is set by CMS, and it doesn't impact any independent critical access hospitals. So the only critical access hospitals impacted by this are Mount Ascutney and Porter. And what we can see over here is that its estimated dollar impact for FY26 is about $100 million. It's a little less, but we don't have estimates in for Brattleboro yet. We know that they will be impacted. We're just not sure exactly what that dollar estimate will be. And so this is a kind of a first step, I think, probably the one that we'll see first and kind of impact our budget process and just the state in general, as we're seeing $100 million removed from the system with this. The next one is reference-based pricing. This won't be impacting us this year for hospital budgets, but we've been directed to implement hospital reference-based pricing through our provider rate setting authority as soon as practicable, no later than 27. So we expect it to make an impact for hospital budgets next year. At a very high level, this reference-based pricing will set a maximum amount that hospitals can accept for payment. This is typically based on a percentage of Medicare, but it can also be based on another benchmark if another one is more appropriate. And again, this is just in response to concerns of Vermont's affordability crisis. It kind of tries to reduce some outlier unaffordable prices, as well as curb our significant cost growth at hospitals, all of which we've talked about today. There's also some important changes to the hospital budget statute. So first, there's a clarification that board enforcement actions are not contested cases. And then the second set of this first slide is about things that the board now must consider when establishing hospital budgets. The first of these is the statewide healthcare delivery strategic plan, once that's been established. So that won't be for this year, that will be for next year. The board also must consider financial contributions to a hospital network and whether those expenses are consistent with the state goals. We also must consider the salaries for hospital executives, including variable payments, bonus pay, incentive plans, and whether these are consistent with state goals. And finally, also must compare hospital executive salaries to the salaries of the lowest paid hospital employees who deliver patient care. And so hospitals will notice that a lot of these questions we've started to ask already this year, these last 3 bullet points, we've started to try to get at and make sure that we're following the statute and making sure we consider these things. We also have some new board authorities. One is to account for hospital deviations from prior budget orders, as well as current budget orders. There's a new reverse CON authority. I'll talk about that in the next slide. Also a new authority to appoint an independent observer upon finding that a hospital has either made a material misrepresentation or is materially non-compliant with a budget order. And finally, a new authority to investigate the financial operations and structure of a hospital network and to recommend actions consistent with the principles for healthcare reform, or once again, the statewide healthcare strategic plan once it's been established. So this is a little bit more about Act 68, which is that reverse CON or notification of service reduction. This essentially tells hospitals that they have to provide notification prior to reduction or elimination of services. They need to provide a notice of intent within a certain amount of time, explain their rationale, explain how it's consistent with the statewide healthcare delivery plan, strategic plan once that's been established, as well as the hospital's most recent CHNA. The board must also evaluate that proposed reduction, look at those things, whether it's consistent with those same pieces, and then also can modify a hospital's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. And this is just a little bit of a timeline for this, since we're kind of fast approaching it. So July, the GMCB staff was researching and doing drafting a lot of draft policy. In August, we are presenting the draft publicly to the board, receiving public comment, and we'll obviously continue to work and revise that policy. And then by September, we'll present that final policy to the board for a vote. And the implementation of this policy will be prior to the hospital budget orders. And just a reminder that this will be a first iteration of this policy with the expectation that this will change. We'll continue to grow and learn from it and make it better suit our needs. And with that, I will turn it over to Attorney Mark Hengster. Thank you.
Hey, good morning, everybody. Mark Hengster, staff attorney for the Care Board. I'm going to go over the process that the board uses to evaluate hospital budget proposals. Go ahead to the next slide, please. So as a brief history, we've shown this slide in years past. The state has had a process for establishing hospital budgets for a long time. There are some new items that came out of the 2025 legislative session, as Emma mentioned, which I'll touch on, but you can go ahead to the next slide. As a high-level background, just talking a little bit about our timing, the board must establish a budget for each hospital by September 15th with a written decision by October 1st. And there you'll see a citation to the budget statute, which I've done my best to update for current citations with the new law. The board must establish hospital budgets that are consistent with the state's healthcare goals as defined in statute. I'm going to talk about those in a little bit. The board has a process to set hospital budget benchmarks, which guide the board in its decision making. I'll talk about that in a moment. And hospitals under GMCB Rule 3.306A bear the burden of persuasion in justifying their proposed budgets. If a hospital does not meet its burden, the board must adjust the budget to ensure consistency with the statutory goals of the healthcare goals. Next slide, please. So a little bit on process. I won't go through all of this, but just a reminder that hospital budget review is quite cyclical, and there's been a lot of work leading up to today and the hearings for individual hospitals that are going to come next. The item that I'll just flag is that in the beginning of the year, staff met with stakeholders to get input on benchmarks and then publicly presented a what we call a guidance document. And that guidance document was adopted by the board, and that document is going to be what I turn to next, which describes the process by which the board evaluates hospital budgets. Okay, so starting point in the guidance document, we have this this image. I'm just going to walk through it for a moment. So part of the board's process in evaluating budgets involves eliciting help from GMCB staff who provide recommendations to the board. Those recommendations are recommendations. They're not necessarily what the board deems necessary to comply with its statutory mandate, but there is a process by which GMCB staff evaluate each hospital budget proposal. So I'm going to walk through this in more detail, but what I want to flag just right now is that there are different sections in the guidance document. The first section describes what the benchmarks are. Those are benchmarks, performance benchmarks that a hospital either does or does not meet in its proposed budget. We'll talk about those. If a hospital meets benchmarks, then you'll see at the top blue box that staff look at the hospital's budget assumptions, they assess them, and then depending on whether those budget assumptions tie out and seem consistent with prior hospital performance, staff either recommend approval or recommend adjustment to the budget. Separately, if a hospital does not meet benchmarks, there's an additional step that staff take, and that's at section 2. So under section 2 of the guidance document, staff look at a hospital that has not met benchmarks, compare it to peer hospitals that have similar characteristics to try to better understand what market factors may be going on that could be the reason that the hospital has not been able to meet benchmarks for the year in question. But you'll see that in addition to that item, the section 3 budget assumptions are still evaluated by staff, and then staff recommends approval or recommends adjustment. Once that staff recommendation is made, the board then deliberates. So that's going to happen at the beginning, of September, after all of the budget hearings have concluded. The board will publicly consider staff recommendations. It will consider its obligations under statute, and it will evaluate whether and to what extent adjustment is necessary for any hospital proposed budget. Next slide, please. So section 1, benchmarks. Under statute, the board has authority to define benchmarks. These benchmarks are designed for the purpose of allowing the board to waive elements of review that it otherwise would consider. And the board establishes benchmarks, as I said earlier, as part of its guidance document, which is published by March 31st. Under rule, the benchmarks are described as a tool that the board can use to consider whether budget adjustment is necessary. Benchmarks also allow the board to exempt hospitals from hearings. We had a board meeting last week about this. Exempted hospitals will not have the core elements of their budgets adjusted, but just to be clear, meeting benchmarks is not the same as getting a rubber stamp from the board. The board still has to engage in all of the statutory considerations that are required. Next slide, please. So this year, there were 3 benchmarks for hospitals. The first was net patient revenue growth, benchmarked at no more than 3.5% over prior year budget. The second, commercial reimbursement rate growth, benchmarked at no more than 3% over prior year budget. And the third, operating expense growth, benchmarked at not more than 3% over prior year budget. And after I go through these slides, you'll hear from Matt Sutter in more detail about hospital submitted budgets and how they align with the benchmarks. Next slide, please. So as I said earlier, if a hospital does not meet any of those benchmarks, staff then turn to section 2 of the guidance document, which is the comparative analytics section. This section explains how GMCB staff evaluate proposed budgets that don't meet benchmarks. Where appropriate, staff compare hospitals to peer groups. Staff review metrics such as operating efficiency, price, access, quality, financial health. And to be clear about what's being done here, staff are not setting benchmarks for each of the measures that they're looking at in section 2. Staff are not deciding this is the appropriate days cash on hand for a hospital to hit or the appropriate operational expense growth for a hospital to hit. Instead, staff are comparing hospitals to their peers to understand if their proposal, which was above the benchmark, is consistent with peer experience. So staff are trying to make some determinations based on other hospital performance, whether the Vermont hospital's experience is justified to be over the benchmark in section 1. And just a note for public interest, both the peer groups for each hospital and the hospital metrics inventory are included in the guidance document, which is on the board's website. Next slide, please. Thank you. So section 3, this is the budget assumptions section, which again applies to all hospitals, regardless if they've met benchmarks. This section explains how staff evaluate proposed budgets for all hospitals. Each hospital, again, bears the burden in justifying its proposed budget. Staff review the budget submission for consistency and accuracy first, making sure that elements tie out. And then staff compare assumptions in the budget to prior budgets and to actual hospital performance. So you'll see a lot from staff on this in the coming weeks, and what you'll see is work in that area. Note that staff may use external data sources to evaluate hospital budget assumptions. Those are described in guidance. And taken together, sections 2 and 3 form the basis for the GMCB staff recommendation to the board. Finally, we get to the deliberative process of the board. So after the staff recommendations occur, the board evaluates whether and to what extent budget adjustment is necessary for each hospital. Staff recommendations assist the board in its review, and the board must establish budgets considering the staff recommendations that meet statutory criteria. And what I'll do in a moment is go through some of these criteria at a very high level and at an incomplete level, but just to give an overview. But what I'll say here is that there are 3 main areas that you could consider as buckets that the board needs to look at. The first is the section of the GMCB chapter in 18 VSA that describes the legislature's intent in establishing the board. The second are the principles for healthcare reform, which are also in the board's chapter in Title 18. And then third is the hospital budget statute, which outlines a number of criteria that the board must consider. And I'll go through each of these individually. So to start, I'm going to begin with the principles for healthcare reform. The board must execute its charge consistent with these principles. And there are a number of them. What I've done here is highlighted a few that seemed most relevant to the budget review that's happening this year. But I note that board members look at all of these individually and consider all of these as part of their deliberative process. So just to read these ones, because these ones seemed most relevant to highlight. 1, universal access to high quality, medically necessary health services. Systemic barriers such as cost must not prevent people from accessing necessary care. 2, health costs must be contained. Growth in spending must balance the needs of the population with the ability to pay for such care. 3, the system must be evaluated regularly to improve quality, access, and cost containment. 4, unnecessary expenditures must be eliminated. This includes administrative costs that do not contribute to efficient, high-quality services or improve health outcomes. And 5, the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. Next slide, please. 9372 is the intent of the General Assembly to create the board. The purpose of the board is to 1, improve the health of the population, 2, reduce per capita rate of growth expenditures for health services in Vermont across all payers, while ensuring that access to care and quality of care are not compromised, 3, enhance the patient and healthcare professional experience of care, 4, recruit and retain high-quality healthcare professionals, and 5, achieve administrative simplification in healthcare financing and delivery. And then finally, the hospital budget statute. So again, there's a lot in the statute. I'm pulling out the items that appear most relevant to cover in a public session. Specific to hospital budgets, to each budget that is proposed, the board considers in part 1, Vermont's critical health needs and resources. 2, actual hospital performance with respect to past budgets. 3, utilization. 4, the efficiency of the hospital's operations. 5, hospital administrative costs. 6, financial contributions to a hospital network, and if those expenses are consistent with the principles for healthcare reform that I discussed earlier. 7, the salaries for hospital executives, including variable pay and incentive plans, and if these are consistent with the principles for healthcare reform. This ties back to the new statutory authority that Emma spoke to earlier. 8, a comparison of hospital executive salaries to the salaries of the lowest paid hospital employees who deliver direct care. 9, public comment on all aspects of hospital costs and use and on individual budgets. And 10, the benchmarks established by the board. And I will just say one thing here before going to the next slide. For clarity, when we talked about that guidance document and we talked about section 2, we talked about peer grouping. And we talked about staff comparing hospitals to other hospitals in similar situations to understand their performance. I just want to identify here up front that the statutory considerations here are not considerations necessarily that require or are appropriate for peer grouping. And I'm just going to point to some of the new requirements. So I'm going to point to 6, 7, and 8. So financial contributions to a network, salaries of hospital executives, comparison of those salaries to lowest paid hospital employees delivering direct care. These are areas where the well, I'll speak to 6 and 7 in particular. These are areas where the board is required to look to the principles for healthcare reform as a comparison. So it's not necessarily appropriate for the board to look and see if Vermont hospital contributions to a network are consistent with other states' individual hospital contributions to networks. Instead, what the board needs to do is look at the principles for healthcare reform, and it needs to decide if any expenses going to network operations are consistent with those principles. So this is different than peer grouping or comparing to other hospitals. Possible that that's relevant, but just want to flag that the analysis there is different than what the section 2 peer grouping items were that we talked about earlier. Next slide, please. So just to recap on this high level, board is tasked with establishing hospital budgets that meet the state's statutory objectives. These objectives tie back, generally speaking, to increasing access, improving quality, and containing costs. Each year, the board establishes benchmarks to focus its analysis and aid discussion with hospitals. Each hospital bears the burden of persuading the board that its proposed budget aligns with the state's statutory objectives, and the board votes additionally on standard budget conditions that apply to all hospitals. And these conditions get incorporated into budget orders, and that's the last item that I'm going to talk about next. So just a little bit of background on this, and you can go ahead and go to the next slide. Each year, the board establishes a budget for each individual hospital and additionally votes on standard budget conditions that get included in the budget orders for each hospital. These budget conditions are generally tied to reporting requirements. They're tied to methods that hospitals need to use to collect data that can be reported to the board. And then there's generalized language that the board is using when it's making determinations about a hospital's net patient revenue cap or its commercial reimbursement rate cap. So what I'm going to do here is walk through these. This is a draft, a staff created draft of the standard budget conditions proposed for FY26. The board is not voting on these conditions today. We're just getting these in front of the public as early as we can in this process. At the end of this process, during deliberations, the board will consider and vote on standard budget conditions. In that process, the board may add conditions, may change conditions, but we just wanted to get these before the public at the beginning of the process. I think what I'll do is, instead of reading through each of these in detail, I'm just going to explain the notation system that exists in the next few slides. And then what I'll do is I'll invite hospitals to take a closer look at this when they have time and evaluate the items that are here. And then, of course, provide any public comment or communicate with the health systems finance team as needed. So just to explain what this is, what we did was we took the standard budget conditions that were used in FY25 budget orders and then began to make changes to those conditions based on what staff perceived would be valuable improvements. Any addition to FY25 standard condition language is notated as underlined text. So as an example, item B has new language. This language is a commercial net patient revenue cap. So this is not something that the board did in FY25, but it's something that staff are recommending that the board consider for FY26 budget orders. And this would mean, if approved by the board, this standard budget condition language would include both an FY26 net patient revenue total cap for each hospital, and additionally, an FY26 commercial net patient revenue cap for each hospital. And that net patient revenue cap would be modeled using the hospital's submitted rate decomposition sheet. As another example here, there's a strikeout on item D, which is in red. And that strikeout means that there was language in the FY25 order that has been removed from the FY26 order. And here that's a minor item, but it's removal of the word expected commercial NPR because, again, this year staff are recommending a commercial NPR cap, which can be used instead of an expected commercial NPR. So that's the way this is notated. The last thing I'll note is that there may be small changes in here that are not notated that were viewed as minor and not substantive to what hospitals are required to do. It's the major items that are underlined as new or stricken out as proposed for being removed for FY26. And you can go ahead and click through the next few slides, which again, hospitals are welcome to look at their convenience.
Thanks, Mark. So I will run through the summary of the hospital budget submissions for 26 with some preliminary analysis by staff. Apologies for the kind of busy table, but there are some adjustments that need to be made in terms of considering the NPR and operating expense growth against the benchmarks. And there were several adjustments that had to be made. Usually these are for provider transfers. But in the case of NVRH, there was the annualized impact of the already approved mid-year request that was approved a couple months ago. And then I'll also flag at Northwestern, they've requested that they be basically held harmless for a $1.1 million expense increase related to OBGYN services, maintaining OBGYN services. Oop. And I am too quick with the mouse, excuse me. And I will also flag at the bottom, you see UVMC's figure for a commercial rate request at negative 7.9. That's the figure presented with the impact of H266 modeled in there, as well as the mid-year rate decrease that they're presenting tomorrow and FY23 enforcement actions. If you remove those, currently staff's seeing it at about a 2.4% increase. I did want to mention staff does have some additional review that we're looking to complete for the UVMC benchmark calculations. We have some questions around the operating expense growth. We just want to understand a little better how the impacts of the provider transfer are being applied into which year, and then how the provider tax is being controlled for with the provider transfer. There was also a accounting change, how they presented their commercial rate growth, where denials are now excluded by payer specifically. So staff is going to work on that with UVM. I will also add UVM staff has been very helpful at answering questions we've had and has been very communicative with us when we've had questions or technical questions related to this. So I have no doubt that we'll get answers to these. I did just want to flag that these are still some open areas for staff's review. Jumping into some analysis, and again, apologies for the very small numbers, but I think I can kind of explain what we're seeing here. So on the left side, you'll see operating revenue growth from 2019. So pre-pandemic. On the right side is operating expense growth since pre-pandemic. And then the colors split out by hospital type. So academic medical center is blue, critical access hospitals are yellow, and red is the mid-sized community hospitals. since 2019, as Emma kind of noted on an earlier slide, operating expenses have grown significantly in hospitals, and we're seeing that obviously on the operating revenue side. Otherwise, hospitals would be absorbing significant losses. So if we compare just NPR growth from 2017 with the prior all-payer model growth target of 4.2%. So essentially, to start from 2017, the actual NPR, trend out what that growth would look like at 4.2% year over year, and then compare that against the actual NPR experience of the system, and then kind of plot that. So basically in 26, if you did that, it's a $291 million difference, where trending out the 4.2% total cost of care growth target, you'd be about $3.5 billion, whereas now we're at about $3.8 billion. If we split this out by hospital type, though, the difference is more dramatic and more apparent at the academic medical center. So again, trending out that 4.2% growth rate from a starting point in 2017, you can see a pretty sizable over $200 million difference in 2026 for the academic medical center, and a much smaller delta for the critical access and mid-sized community hospitals. So taking this slide right here, basically wanted to plot like cumulatively what it would look like, the cumulative NPR in excess of the 4.2% all-payer model growth target. That is a mouthful, but cumulatively, what does this experience result to? And what we see is a $684 million NPR over the all-payer model target at the academic medical center. We're actually under at the mid-sized community hospitals through 26 at $60 million under, and then the critical access hospitals over by about $72 million. Jumping to this year's budget, if we just consider, we're kind of seeing an similar experience where NPR increases are heavily skewed. If you look at the system NPR increases, we're seeing $125 million budget to budget. The health network hospitals account for about $98 million of this, or 78%. And here's just a waterfall graph showing where our starting point in 2025 total NPR, and then how we get to the submitted FY26 budget, and then individual hospitals' contribution to that increase. I'd like to, next few slides, I just want to focus on some financial ratios. So first, we'll look at some profitability ratios. These are kind of pretty straightforward things like income and margin. Then we'll look at liquidity ratios and some solvency ratios also. So just to kind of show maybe explain how to read this or interpret these lines. Operating income is pretty straightforward. It's just normal operations of the hospital minus expenses. So for this, you can see UVM's budgeting $72 million in operating income this year. That's a $6.3 million increase from where they're expecting to land in 2025 projections. So interpreting this system-wide is $76 million increase, or $76 million budgeted in operating income, which is about just under $3 million increase from where they're projecting to land for 25. But if we exclude UVM from that calculation, we're seeing only a $4 million increase, or $4 million of system-wide operating income, and which is a deterioration of about $3.6 million from their current projections. Operating margin is just the operating income as a percent of total operating revenues. So here you're saying like system-wide 1.7% operating margin, basically break even if you pull out the medical center, however. And then total margin slightly improved from operating margin because it includes non-operating revenues in there, but kind of a similar experience to operating income and margin. Jumping to liquidity measures, I'll do the same thing and just kind of interpret the lines. So starting at the top line here, UVM Medical Center was budgeting 134 days cash on hand. That's a 6.6 day improvement from where they're projecting FY25 to end up. If we go down to the bottom here, look at this at a system level, system-wide about 124 days cash on hand, basically even with where we ended up, where they're projecting to end up for 25. And then if you exclude UVM from the calculation, that pulls it down to about 111 days, and then a 9-day deterioration. Continuing down here, you also have, we were showing days in patient accounts receivable. Lower is better here and usually reflects more efficient billing and collections. The way you got to think about this is how many days worth of expenses are sitting or that need to be collected. System-wide, you see kind of an average. It's pretty consistent year to year around this like 40-day range. There are some outliers. Brattleboro is significantly higher at around 90, Springfield at 70, and then Grace Cottage at about 61. And then current ratios are just kind of a ratio of their current liabilities to current assets to current liabilities. Looking to some solvency ratios. So this is more considering these look more towards your hospital performance against like how much debt you have essentially. So debt service coverage ratio, you can see top line of 4.7 for UVM, which is fairly similar for like the system average below. And then cash flow to total debt is sort of it's looking at your amount of cash flow, so income, and then we're backing out essentially including depreciation and amortization expenses back in those non-cash expenses back in there, and then basically showing it relative to your total debt. And then long-term debt to capitalization kind of shows the ratio of long-term debt to your overall net assets. So it can kind of illustrate, hospitals or systems that are more reliant on debt financing. And I will note that all these deltas here are relative to FY25 projections for these financial ratios. We do collect utilization information from hospitals. A summary look it's kind of difficult to present based on how they're reported by hospitals, but we did want to provide just a quick summary table of inpatient admissions, outpatient visits, and ER visits, and then the hospital submitted budget their change relative to the FY25 projection. So a couple do jump out are the large increase at Gifford Medical Center, which we are asking them about for inpatient admissions. If you're seeing some decreases at UVM for inpatient and increases in outpatient, we're not seeing any hospitals projecting decreased outpatient visits. And we also collect pretty detailed staffing information broken out between clinical and non-clinical positions by department. Not all hospitals are the same. They all have different departments and different structures. So it's a very detailed, granular look at this we have. So what we tried to do here was just start very high level clinical positions, non-clinical positions, major service areas, and then just split it out by hospital type, like we've been showing for the other slides. And so here you're seeing kind of across the system, some small decreases about between like 1% and 2% in non-clinical positions and some small increases in clinical. I'll note that there's the clinical increases, the additional hires or additional clinical FTEs are concentrated in the critical access hospitals. But also that there's an increase in physician office practices in the clinical side here as well. So that is our summary of hospital FY26 submissions. Next steps are the hospital hearings, as mentioned at the outset. Mount Scottney and SDMC are today, this afternoon. So Chair Foster, I will pass it back to you for questions or public comment.
Thank you all very much. That was really very informative. I didn't have any questions. I just had one observation that I thought I'd make as we contemplate different healthcare reforms that are potentially available to the state as tools to combat these challenges. And one is it's very easy to Monday morning quarterback anything, but the all-payer model and evaluating our cost growth on an all-payer basis to me seems misguided. The goal of the all-payer model is 3.5 to 4.2, but with Medicaid generally 0 to 3 and Medicare 0 to 3, it disproportionately puts that on commercial. And I think even if we hit it, you still would see a real big steep increase for commercial. So I think as we think about these and what the problems we have going forward, recognizing that I think is important. But otherwise, I didn't have anything else. I'll open up to other board members for any questions or comments.
I can start off. Thank you, Matt, Emma, and Mark. And in Emma's opening, she started to talk about cost to payment ratios. And it's commonly discussed around the state that the payments from public payers are insufficient. But when we look at the rest of the slides, it appears to me that the problem isn't so much underpayment from public payers, but the rapid growth in costs and operating expenses across our hospitals, particularly the academic medical center. Did I understand that part of the presentation correctly?
Yeah, the cost coverage information was mostly presented just to illustrate that imbalance between commercial and public payers. Yes.
Yeah, so if the payments from public payers are known and the ratio of cost to payment is getting worse and costs are going up, it's the rise in costs that are driving the declining ratio, is it not?
Let me get back to you on that. I would need to understand the methodology a little bit better for how they calculate the cost coverage ratios. Right. But okay. I'm following the logic though. Yes. The logic follows. Yeah.
Okay. I did understand that there's rapidly growing operating expenses in our hospitals and primarily at the academic medical center. That was a main point of the last few slides. If I want to make sure that I got that correctly.
Yes.
Okay. Thanks. Great job. I appreciate it.
I don't have any specific questions right now. I really appreciate the presentation, Mark. I really appreciate your clarity. Thank you.
Chair Foster, this is Sarah. I think I'll jump in.
Please.
So I obviously need a little more time to absorb this, but I did have one question about the staffing data that you provided right at the end. And do you know if those numbers include the announcements that we've been seeing over the past week or so?
I don't, but staff can do a comparison, or we'll have to just reach out directly to the hospitals, confirm whether or not it's built into the submission. But no, I don't know for sure.
Okay, thank you.
I don't have any questions. I just want to thank everybody for all the hard work I know that's gone into these presentations and the analysis of all these hospital budgets. And I got to dig in. I am digging in. It's going to be a long few weeks, but I appreciate the foundation that was provided today. Thanks.
I also wanted to recognize just our staff and also all the hospital staff and public who have worked on these budgets already. It's not just an immense amount of work for the board, but also for the staff, more so the staff, and also for all the hospitals and their staff. And just from my perspective, it's clear there is a pretty significant acknowledgement of the affordability crisis we have, and a lot of effort made on the hospital side to look at our budget guidance and try to adhere to it really closely. So I did want to acknowledge that and appreciate that. With that, I know that the CEO of the Hospital Association had wanted to make a comment. Mr. Del Trecco, are you here?
I am, Chair Foster. Thank you. I appreciate the time. So good morning, Chair Foster, members of the board, and members of the public. First, I want to thank and echo some of your thanks to the board and the budget team for your work leading up to this. And on behalf of all Vermont's not-for-profit hospitals, thanks for the opportunity to speak to these budgets. I also want to acknowledge every single hospital employee across Vermont. They're rising to the challenge and doing more with less every day. So thank you for your professionalism, skill, and compassion and care you bring to all Vermonters. We heard during the insurance rate review hearings that families are facing premiums approaching $50,000. We believe that's unacceptable. Affordability is the heart of healthcare reform and directly impacts access to care. Vermont hospitals are committed to providing affordable care while maintaining access to services in their communities. It's one of the principles of reform, and balancing that is important. The commitment is reflected in both our long-term transformation work we're doing with all of you and the immediate choices you'll see in these budgets. I'm sure you've read the news. Many of our hospitals are already putting into motion plans to realign services and reduce staffing where they can do so responsibly. They have emphasized administrative savings first and carefully evaluated areas where changes can be made with the least impact to patients. They've heard the call to act and are responding with compassion and competence. Hospitals are committed to ongoing transformation work, and additionally have engaged with Kaufman Hall to identify evidence-based changes that can improve care delivery and operational efficiency. That work is ongoing. As new opportunities come forward, we must carefully measure the pros and cons of each. Surprises can't be part of this process because they lead to real harm in our communities. Unfortunately, and as a result of the ecosystem challenges we face, hospitals have largely become a safety net for care. Hospitals are always open, always staffed, and always available no matter the time of day or night. And in many instances, this is far from ideal. It's expensive and at times not what's best for the patient or the providers. Take, for example, the idea that 30% admissions are avoidable. We hear that frequently. If a patient doesn't have another, more appropriate care setting, that admission, unfortunately, is not avoidable. This is especially true in our emergency departments. This is why real transformation means filling in the gaps of care. We just cannot magically shift care away from hospitals. To do so, we must build capacity elsewhere, and we need the whole system to be at the table to succeed. This will take real investment. We're also looking at how this work gets funded. We need payment models that are fair and sustainable and that create the right incentives. Just having rate restrictions is not viable. We already know that from our experience. Finally, this work will only succeed if supported, not just by hospitals, but by the administration, the legislature, the Green Mountain Care Board, and every healthcare stakeholder. We need resources for transformation, and our communities need clear communication about what is changing and why. Without that, I fear we'll be right here, back here next year. As we lead into these 26 budgets, every hospital built its budgets with two things in mind: affordability and patient care. These budgets are lean. In fact, some hospitals submitted budgets with negative operating margins, and those decisions were not made lightly. There will likely be service line changes in the near term, changes that will increase travel time, impact access, and delay care. If those changes become necessary, we must proceed carefully. We must work together to avoid harm to Vermonters. Over the course of the hearings, you'll hear about some of these difficult choices our hospitals are making. I can tell you I've personally spent a career building hospital budgets, reviewing them, and I can tell you the ones that have been submitted are among the leanest I've seen. My early analysis of the data from these budgets indicates downward pressure in all areas of the guidance set by the Green Mountain Care Board. Net patient service revenue, the guidance was set at 3.5%. Again, based on my early math in the information provided, hospitals have submitted 2.17%. Operating expense growth, the guidance was set at 3%. Hospitals submitted 3.36 as a system. And it's important to understand how we got there. We know that 3% is an increase, but they had to make significant reductions. For context, the approved Green Mountain Care Board compounded annual growth amount for the last 3 years was 8%. That was the approved amount. The submitted budgets represented $225 million in reductions from those approved levels. This is the lowest operating expense we've seen since 2019. And for rate increases, the guidance was set at 3%, and the system-wide rate request was 0.81%. That's the average. Again, one of the lowest we've seen. I want to acknowledge it took 3 major efforts to get there. Some of that was budget enforcement by the Green Mountain Care Board. Some of it was legislative changes. And finally, others were hospital-led efforts to control growth and address affordability. The result is lower prices for Vermonters. Our commitment to you during this process and as we move forward, we're committed to examining every opportunity to improve how care is delivered and how operations run because Vermonters deserve it. We're committed to looking at every option thoughtfully, weighing those trade-offs and doing again what's best for Vermonters. I'm optimistic that if we continue to do this work together, the efforts will lead to savings, better care, and more sustainable system. Again, but this will take real investments. Every Vermont hospital is committed to doing this work. And I ask the board, as you review these budgets, to support them. I truly believe reductions beyond what has been submitted will challenge transformation efforts and the ability for hospitals to meet the needs of their communities. I want to thank you for all of your work leading up to this and the work you're about to do. And I appreciate the time this morning.
Thank you very much, Mr. Del Trecco. I really echo and emphasize your remarks on the need for system-wide transformation. And I appreciate your comment. It's not a light switch. We can't just move care out of hospitals. We have to fill the gaps. And I think fortunately the state has engaged for now 3 years and invested in that. Hospitals, legislature, the care board, AHS. And so we are, I've said this before, but we're at the point where we're ready to make the changes we need to make. And so thank you for participating in that effort and your members. I'll turn to Mr. Fisher from the Healthcare Advocates Office.
Thanks, Mr. Chair, and thanks, Mike Del Trecco, for your comments. I appreciate them and agree with much of what you said. And I also wanted to, say my own thank yous to everyone who's worked hard to get us here and will continue to work hard over the next couple of weeks to get us to the next step. Of course, board staff, board members, and the leadership at Vermont Hospitals, as well as the rank and file folks at Vermont Hospitals who are providing care today. I don't know if people have noticed, I've sort of stopped using the term affordability in this context. It's not that I don't want, of course, I want affordability for consumers who are getting care today or who are trying to buy coverage. But I have tended to use the focus more on whether our healthcare financing system, such as it is collapsing or at risk of collapsing. That's a different version. That's a bit of a different take. Of course, it relates directly to consumer affordability. But my concern lately is much worse than affordability. On top of more people being priced out of the ability to get the care they need or coverage they need, I am fearful of us spending more than we're raising. Quite frankly, that is my fear. That current trajectories. So I appreciate all the work that's gone into producing the budgets that are in front of you. And I guess I have a little bit of a different take. We will be here next year. I am sure of it. I hope we are. And we will be facing similar challenges because the efforts that led to the budgets in front of you today are the start, or the next phase, maybe I should say. This is going to take more concerted effort over a number of years to attempt to get us into more reasonable prices for our system. So enough for me. Thank you, everyone, and look forward to hanging out with you all quite a bit over the next couple of weeks.
Thank you, Mr. Fisher. And thank you for your team's work. Your team always adds a lot of value to this process as well. And I appreciate that. I'll turn to public comment via raise the hand. Ms. Wasserman.
Yes, good morning. I just have a short comment, basically about the hospital budget data standardization. Act 68, otherwise known as S126, states, I quote, "Hospitals shall submit information as directed by the board in order to maximize hospital budget data standardization and allow the board to make direct comparisons of hospital expenses across the healthcare system." Hospital budget transformation can be incredibly valuable in a whole variety of areas. I'm thinking of travelers, comparing one hospital to the next, as well as administrative overhead. And it could be particularly relevant to the development of reference-based pricing. So the hospitals are now mandated to do this. The question is, when will the hospitals submit their standardized budget data to the board so that the board can make these valuable comparisons of hospital expenses, one versus the next? Thank you.
Thank you, Ms. Wasserman. Any other public comment at this time? Okay, seeing none, I think we can take a recess and the boards will come back at 12 o'clock for the Mount Scottney presentation and hearing. So we will adjourn till 12 o'clock. Did I have that right? I think it's 12 o'clock. Hang on, let me just double check that.
Yeah, you're right. It's Abby.
Okay, sorry.
You're
Thanks. Okay, so we'll see everyone at 12 o'clock. Thank you.